This is part two of the cervical projections. We are going to start with the open mouth position. Image analysis guidelines for the open mouth position state that the atlas should be demonstrated symmetrically seated on the axis, with the atlas's lateral masses at equal distances from the dens. Your spinous process of the axis is aligned with the midline of the axis's body. This is how you determine if there's any rotation. The mandibular rami should be visualized at equal distances from the lateral masses. Again, you can determine rotation from here. Upper incisors and the occipital base are seen superior to the dens and the atlantoaxial joint. So we should have an open atlantoaxial joint space, and the lateral masses should be free of any superimposition, or nearly free, as you can see in this projection here. Dens is at the center of the exposure field, and the atlantoaxial and occipito-atlantal joints, the atlas's lateral masses, transverse processes, and the axis's dens and body should all be included within the exposure field of view. Here are those image analysis guidelines for your review. Before we move on to some determination of image analysis and patient rotations and things of that nature, I wanted to go over the central ray alignment for a cervical spine when a person presents with trauma. Typically, when a patient presents in a trauma situation, they are placed in a collar. That collar causes the line connecting the incisors and the mastoid tip to actually sit 10 degrees more caudally, okay? Thus, the base of the skull, when you open the mouth, will be superimposing the dens and the atlantoaxial joint space. So how do we circumvent this? You can direct the central ray in alignment with what we call the IOML. That line is the line connecting the inferior orbital rim and the external ear opening. If you align the central ray caudally with it and perform the projection as an open mouth, you should be able to get a atlantoaxial joint space and the dens free of superimposition. With that being said, you do not want to rotate the head or do any type of tilting. You just want to use your alignment with the central ray with the IOML. Now, if you don't want to use that, there are times you will see that in the field we will tilt the bed instead of and leave the central ray perpendicular to align the IOML. In this projection of the open mouth, this is a trauma situation where a patient is in a collar. So therefore, we cannot adjust the patient's positioning. We have to adjust our central ray. So for trauma positioning, an insufficient caudal angulation will cause those upper incisors to be demonstrated superior to the dens, and the dens to be superimposed over the occiput. Okay, so you'll have to realign that central ray from perpendicular to align with the IOML to correct your positioning, or you can use some bed tilting for that. In the case if this was non-trauma, we would need to bring the teeth down, or the mouth head downward, and open the mouth so that the upper incisors and the mastoid tips were superimposed. But this would be only if we weren't in a trauma, the patient was not in a collar. In some cases, we can have, this is another trauma situation, okay, where the patient is in a collar, and there can be excessive caudal central ray angulation. If the central ray was angled too caudally, the occipital base will be demonstrated superior to the dens, and the upper incisors are superimposed over the dens. So in this case, again, you may need to tilt the bed to align that IOML perpendicular, or with the parallel with the central ray, or you can tilt the bed. In this case, if the patient was not in a trauma situation, you would need to realign the upper incisors to be in a line with the mastoid tips so that we can get that occipital base superimposed with the teeth, and the allantoaxial joint space free of superimposition, and those mastoids and the lateral masses, sorry, and the dens free of superimposition. So let's look at our first practice analysis. If you take a look here, we're looking for the open mouth projection. We're looking for an open joint space, allantoaxial joint space. We want to see the dens free of superimposition, and we want to see these lateral masses free of superimposition. And so, you know, we are positioned over the anatomy of interest, but we don't see any of those things. So the first thing I'm going to look at is, where is my occiput in relationship to the masses and the dens, and where are my teeth? And so the occiput is actually superimposing the dens, and so that should let you know that you have your upper incisors to superior to your mastoid tips. In order to correct this positioning, we need to lower those upper incisors until the lower edge of the upper incisors are in alignment with the mastoid tip and are aligned perpendicular to the IR. In this projection as well, there is a little bit of rotation that you can see. If you take a look at the joint space over here and the joint space over here, you can see that there is the dens, the lateral masses to the dens, and from the mandibular rami to the dens are narrower on the left side than on the right side. So we also need to fix a little bit of that head rotation. We need to rotate that face towards the left side until it is facing forward. In our second practice analysis, you definitely want to make sure that you have all your anatomy. And in this projection, technically we do not have all our anatomy because it's not well visualized. The first thing I want to look to see is, where is the positioning of my occiput and my upper incisors. In this projection, the upper incisors are actually superimposing over top the dens here. So that should let you know that the upper head is faced downward, where we will need to again align those teeth with the mastoid tips and with alignment perpendicular to the IR. Another key positioning error we need to look for is rotation. Again, you can see there's a lot more space on this right side of the mandible, and then there is on this left side. So we need to rotate the face forward towards the left until it's facing forward. If this was a trauma situation, you may have to realign the central ray cephalically. This ends part 2 of the open mouth projection. Please move on to part 3 for our lateral C-spine projections.